So I'm going to place this on my heart so that you could hear my heart. You should hear a lub and a dub. So S1 and S2. Okay. Okay, so we were able to hear lub dub, lub dub, lub dub. Okay, I'm going to place this on your heart and you can listen. I'm going to sanitize that one more time. Okay, perfect. Let's start over here. This is the aortic valve. Okay, pulmonic. Okay, tricuspid. It's a little harder to hear with the shirt. And then if you're able to displace your breast tissue, mitral. Each of those have a valve, and that means we would have 4 valves. So we have 2 pairs of each. We have the AV valves, or atrioventricular valves, that consist of the tricuspid valve and the mitral valve. The tricuspid has 3 valves, and then the mitral has 2. The mitral's on the left, and the tricuspid is on the right. Okay. After that, we have the semilunar valves. So we got the pulmonary valve as well as the aortic valve. So those prevents the backflow of blood back into the heart once it's being oxygenated, and it prevents the backflow of blood to the lungs as well. That's why it's called pulmonary. So when I place my stethoscope, there are 4 main locations called the aortic, pulmonic, tricuspid, and mitral. And essentially, I'm listening for the sounds of those valves. They can be found across the chest. So after the blood gets oxygenated by the lungs, it's brought back to the heart by the pulmonary veins into the left atrium, to the left ventricle, then to the aorta, and it must pass through the aortic valve. So there should be 3 there, right? So if you only have 2, then now it's back flowing to the left ventricle, and which can then backflow back into the lungs. So the symptoms would be different because it's not backflowing to the liver, creating the ascites and the spider nevi and the jugular vein distension. It's creating pneumonia because now the lungs are being overfilled with fluid and the lung is unable to bring it back. So that depending on where the missing valve is, that could dictate the symptoms that you will have. And that's also the difference between right-sided heart failure and left-sided heart failure. Left-sided, more chest congestion. Right-sided, more hepatic congestion. Therese.
Hi, Dr. Hiraya.
Welcome back to the clinic. So earlier on, we had a little bit of a pre-discussion before we go ahead with a physical examination. Thank you, first of all, for coming into the clinic and sharing some of those information with me. It's not always easy for people to talk about what's going on internally. So I truly, truly appreciate you being open and honest and sharing some of those vulnerabilities. So now we're going to be moving forward to the second part of the medical examination, which is going to involve the physical examination. And I know I mentioned before, but I just want to say again that this examination is going to involve me having a look from your face area, under your eyelids. I may take a look at your neck area as well. Have a listen with my stethoscope and feel around lightly press with my hands. I'm also going to look at your extremities, which are your arms, hands, fingers, toes as well. And then we're going to have a listen to your heart. I may place my hand on your chest to feel for certain vibrations. And also, I'm only going to expose the areas that I need to. And if at any point you feel uncomfortable or you feel discomfort, you can let me know. And you can stop the exam at any time you wish. Just let me know. Is that something that's okay with you?
Yes.
Okay, perfect. So before we begin, I'm just going to sanitize my hands and don on some gloves. and then we're going to proceed. Okay, so before we begin all of that, I'm going to take what are called vital signs, which is going to involve your blood pressure, your temperature, your respiration, and your heart rate. Is that something that you're okay with?
Yes.
Okay, why don't we get started with your blood pressure? So before I place this equipment on you, I'm just going to sanitize everything. I'm going to sanitize the stethoscope. Perfect. Just going to place this here if that's okay with you. Okay, good. So we'll start with your blood pressure. So I know you have that gown on. Are you able to expose your arm? Oh, maybe. There we go. Yes. Okay. All right. The first thing I'm going to do is just feel your pulse here. Okay, I'm going to squeeze this. It's called a sphygmomanometer. What it does is when I squeeze it, it creates pressure around your artery. And it occludes the blood. So then when I stop feeling your pulse, then that's how I know it's reached its maximum. And that's how we find your baseline. Okay, I don't feel it at 110. So what we're going to do now is if you could lift your arm up and just squeeze it 10 times, that's going to reset it. 10. Okay, perfect. Now I'm going to have a listen with my stethoscope. remove this. Okay. Alright, I'm just going to write that down. So your blood pressure is 102/63. So it is rather low, and I think that was the case last time you came in as well. Okay. Next, I'm going to ask you to place this under your tongue, and that's how we're going to check your temperature. This is a thermometer, so you can...
Can I touch it, doctor? Or no?
1 second. Let me just... 1 moment. Okay, there we go. Okay, so you can just place it under your tongue. You can hold it and place it under your tongue. Okay, so now we're going to, while that's happening, I'm just going to check your pulse and respiration. Okay, we got it. Thank you. Okay, 36.2. So you don't have a fever. Okay, now I'm just going to check your heart rate and your respiration. Okay, so your heartbeat's a little bit slow, okay? The pulse is strong, so that's a good sign. And your respiration is within normal, it's 18. Okay, so I'm just going to write that down as well. Do you have any questions before we proceed? Okay. So that's just pretty standard, something I do with everyone. And just to get a bit of an idea of where they are today. Okay. Okay, so now, 1 second. Okay. So next, I'm just going to have a look at your face, your neck, extremities, as I said. So I'm just going to put this aside here. I'm just going to place your eyelids down, if that's okay. All right. Okay. I do see a little bit of pallor, just like last time. And if you can look down. Okay. And I don't see any jaundice of the sclera. Gonna take a look at your mouth as well. Are you able to say ah? Are you able to stick your tongue out? And could you lift the tip of the tongue to the roof of your mouth? Good. Okay, so I could see those veins. They're nice and bluish. That's good. Good sign. I don't see any bluish tinge discoloration that we spoke about earlier called cyanosis. Now, I'm just going to look at your neck vessels as well. So if you just look up with your chin, I'm having a look at to see. Okay, I can see I'm looking for any pulsations, any lesions and masses, which I don't see. I do see a pulsation on the right side. Now, in order to distinguish whether that's the carotid pulse or the jugular pulse, which we'll measure later, is just by placing my hand on it. Are you able to turn your head towards the wall, towards here? And just, okay, there we go. Alright, it's definitely the carotid pulse because the jugular pulse will disappear when you press on it. And that's because a superior vena cava doesn't have any valves, which prevents the backflow. Okay, I'm just going to continue on with the examination now. I'm going to take a look at your extremities, so just your hands. So I'm looking at the nail beds. Sometimes we can see what is called clubbing, not like in the nightclub, but the spooning of the fingernails, which will dictate that there's been chronic lack of oxygen. We see this in patients with something called COPD or chronic obstructive pulmonary disease. So I don't see any of that, and I don't see any of the bluish tinge that we mentioned, and I don't see any discolorations or nicks. If you can turn your palm over, also gonna see if there's any signs of circulatory disorders such as in Raynaud's disease. When I press over here, everything's good. Also, I'm gonna do that same thing over here. Okay, just press. So that's capillary refill is within 2 seconds. That's normal. So the same idea here. Okay, good. You haven't noticed any numbness or tingling in your fingers or toes? Good. So I'm also gonna do the same thing with your feet here. So what I'm doing is I'm checking your pedal pulses. So I got the medial malleolus and the dorsalis pedis. I'm also going to check for pitting edema. Sometimes that could happen with certain cardiovascular diseases where fluid accumulates and it's like you've been on a really long flight and your feet are just swollen. And that's because the heart is having a hard time, or the body is having a hard time bringing the blood back to the heart. Okay, good. So no problems over there. Alright, so next we're going to... I've taken a feel of your carotid pulse. I'm also going to have a listen to that area as well. And for this, we're going to listen with the bell of the stethoscope. And what I'm looking for is any kind of turbulent swishing sounds, which are called bruits, which can indicate that there could be something going on with the heart. So if you just turn over here. Okay, and if you turn towards the other side. So I didn't hear any bruits there. All right. Okay, now that we're in your neck region, we're also gonna see if I can measure your jugular venous vein. So this is the superior vena cava, which transports deoxygenated blood into your heart, specifically the right atrium. Okay, So for that, we're going to need 2 rulers, and you're going to need to be seated 45 degrees, which you are. Typically, we do this on the right side because it's much easier to measure that way. And we just place 2 rulers, like so, parallel to one another. And if you're able to turn this way, we can see the pulsations. Okay. Alright, so it's within normal. It's less than 2 centimeters. When there is a liver pathology or a backflow of blood to the superior vena cava, it could push up the pulsations up higher. Okay, so if there's a liver pathology, I've seen it in my patients where it's accompanied with jaundice or yellowing of the sclera, as well as ascites, which is fluid buildup into their peritoneal cavity, which is in the abdomen. So those symptoms are typically found together along with spider nevi in their abdomen. That's because the liver is having a hard time. There's a vein, they're called the hepatic portal vein, having a hard time pushing all of that blood that's supposed to have been filtered up into the superior vena cava back to the heart. That's not the case here. I don't see any of that, so we're not concerned about that. But I just like to explain what I'm doing to my patients so that they're also informed and educated and they can learn something about themselves throughout the examination. And I feel that helps them feel more comfortable with the examiner and also feel empowered that they know what's going on in their own body. So we've palpated your neck area, which meant just pressing lightly. We took a listen to hear for any abnormal sounds, and we've also measured the jugular venous vein, and so far I didn't see any abnormalities there. So we can go ahead and continue downwards towards the precordium, or the chest area where we would examine for heart pathologies. Okay, so before I place my stethoscope, I'm just going to place the side of my hand, and I'm going to be feeling for vibrations called thrills. Okay, so I'm just going to do that now. Okay. A thrill can sometimes be felt like a cat's purr. If you've ever had a cat sit on your chest and they kind of vibrate, that's what I'm searching for. But in this case, that wouldn't be a good sign. Are you able to displace your breast up? I'm just gonna place my the left one. If you could just can I guide your hand? Yeah, if you just take your breast and place it upwards. I just need to access the 5th intercostal space, mid-clavicular line. That's where the apical pulse is. Okay, I don't feel any thrills in that area. Okay, thank you so much for allowing me to place my hand on you. The next step is something called percussion, which in this case, we could do if I suspect an enlarged heart. Now, for people who have breasts, it can sometimes not be easy, so we're going to skip that portion and go ahead to the auscultation, which is listening with the stethoscope. So the heart has 4 chambers. So if, just before we begin, I like to explain what's happening. The heart is a pump, but more specifically, it's literally 2 pumps. One pump pumps blood that's deoxygenated, meaning it doesn't have oxygen yet, into the lungs, and one of the pumps it into the body after it's being oxygenated. Okay, so if we divide the heart in half, you have the left side and the right side. Okay, so when I'm listening with a stethoscope, I'm actually listening to what are called valves that prevent the backflow of blood into these chambers called the atria and the ventricles. We have 2 atrium, the left and the right, and we have 2 ventricles, the left and the right ventricle. Each of those have a valve. And that means we would have 4 valves. So we have 2 pairs of each. We have the AV valves, or atrioventricular valves, that consist of the tricuspid valve and the mitral valve. The tricuspid has 3 valves, and then the mitral has 2. The mitral is on the left, and the tricuspid is on the right. Okay. After that, we have the semilunar valves. So we got the pulmonary valve as well as the aortic valve. So those prevents the backflow of blood back into the heart once it's being oxygenated, and it prevents the backflow of blood to the lungs as well. That's why it's called pulmonary. So when I place my stethoscope, there are 4 locations, main locations, called the aortic, pulmonic, tricuspid, and mitral. And essentially, I'm listening for the sounds of those valves that can be found across the chest. To make it easier, I have a diagram to show you. This is a textbook that I use for, gosh, it's probably 14 years old. It's when I first started my studies. So we can take a look. Oh, sorry. I'm just going to place this here, and I can show everyone on the camera as well what that looks like. Heart. Okay. The heart is a really, really fascinating subject. It's one of my favorites. This is a really good diagram. So I don't know if you can see this. It'll be upside down from where you are. But essentially, that's your heart. So if that is fitted right here in this area, you can imagine. Okay, so this is the first chamber, which is the right atrium. This is the superior vena cava. So when we're measuring your jugular venous vein, this is your neck area. We're measuring the flow of blood here. And also, deoxygenated blood comes from down here, the inferior vena cava, and goes to the first chamber. Atrium in Latin means room. It goes to the first room, the right atrium. There are no valves there, so there's free flow of blood. That's why when we press it, it sinks, because it doesn't have the ability to push back. So blood collects over here in the first atrium. You'll see these little web things. This is the first valve. This is the tricuspid valve. Those things are called chordae tendineae. It's kind of like spider webs. There's 3 valves here preventing the blood from backflowing back into the atria once the blood goes to the first ventricle, the right ventricle. How the heart works. There's a node here called the sinoatrial node, which conducts an electrical current. Once that electrical current gets activated, it travels down the bundle of His and to the rest of the heart, called the Purkinje fibers. And essentially, like a battery that's being jolted, it works. So then the atria contracts. When the atria contracts, it pushes the blood to the ventricles. And when the blood fills up, the door, which is the valves, closes shut. And that's why we hear that first heart sound, the lub. So the heart sounds like lub-dub, lub-dub, lub-dub. So we hear the first lub when the first set of atrioventricular valves shut. Now, what's happening on the right side here is also happening on the left side at the same time. So I said the heart is 2 pumps. That's because the ventricle will then push that deoxygenated blood into this pulmonary artery, into the lungs. It branches out to the lungs, right? So that the lungs can bring oxygen into the blood. That's why we breathe. You know, the air goes into the lungs, carries oxygen. So once that electric current conducts this way, then the ventricles then contract. And when the blood gets pushed out, then the semilunar valve, in this case the pulmonary valve, which has 3 valves, shuts, and that's when we get the S2 or the dub. So that's why we got the lub, dub. Now what's happening on the right is happening on the left. On the left side we have the mitral valve, which has 2 valves over here. So that closes along with the tricuspid valve. These two are paired. So when this contracts now, it takes the oxygenated blood from the lungs, brings it down, closes it shut from the left atrium into the left ventricle, and then pushes it out through what is called the aorta, this big red blood vessel, one of the biggest vessels, which branches off to the carotid artery. So that's when we're feeling your carotid pulses and listening for bruits. It's one of these branches over there. We got the internal, external. Okay, so when that gets pushed out, there's also a valve there. You can't see it in this diagram, but it's behind there. It's the aortic valve. So these, the aortic and pulmonic, closes together. That's the dub, S2. And the first heart sound, the S1, is the atrioventricular valves, the tricuspid and mitral. And that's what exactly we're listening for when I place my stethoscope in these areas. Okay, so just to summarize what we talked about, there's 4 chambers in the heart, 2 atrium at the top over here, and 2 ventricles. Okay, so the first ventricle, the right ventricle, is responsible for bringing deoxygenated blood into the lungs through the pulmonary artery. Any vein that removes, any blood vessel that takes blood away from the heart is called an artery, and any vessel that brings blood to the heart is a vein. There's a common misconception that veins only carry deoxygenated blood and arteries only carry oxygenated blood. It's not the case in here because the ventricle is pumping blood out of the heart through an artery, and that blood is not oxygenated yet. It's going to the lungs, so through the pulmonary artery to the lungs. Then the pulmonary veins bring it back, this time to the left atrium, goes to the ventricle, that shuts, and then the left ventricle pushes it out to the aorta, to the rest of the body. This is really important to understand when we're having a listen. When I place my stethoscope on the aortic, which is the second right intercostal space, the pulmonic, second left intercostal space, tricuspid, and mitral points, because I'm listening for those specific heart sounds. Also important to note that sometimes it's easier to hear these sounds based on their location. So S1 tends to be more prominent in the apex, which is this pointy part of the heart, and S2 is more prominent in the base, which is the top part of the heart. So the heart is kind of like an upside down triangle. Really beautiful organ. I know that's a lot of information, but do you have any questions? Yeah. Over here you can actually see the flow of blood. So the blue carrying deoxygenated blood goes to the heart, goes to the lungs, goes back to the heart, and then comes out red to the rest of the body, because red meaning it's being oxygenated. There's the liver, and there's the hepatic portal vein that we were talking about earlier, and your carotid arteries would be right here on the neck area. Yeah, it's cool, in my opinion, if you're a nerd. So, now we can put this away. It's a heavy book. I've got about, I can't even remember how many. Alright, so now let's go ahead and have a listen. Okay. So first I'm going to listen with what is called the diaphragm of the stethoscope, which is the wider part, and then the base, which detects more lower pitch frequency sounds, just like the bruits that we were listening to. So that's the bell, there's the diaphragm, and then there's the bell. Okay. Starting with the aortic pulse. I also want to emphasize that just because when I'm listening for a long period of time, it doesn't mean that there's something wrong. It's just I'm listening carefully for everything, so sometimes it may seem like I'm listening for a long time. would you be able to move your breast tissue upward again like last time? Okay. And I'm just going to listen here. This is called the Erb's point, mid-sternal. Okay. So now I'm going to listen with the bell. Aortic. Pulmonic. Mitral. And then if you could just place your breast tissue upward again. So this is the mid-clavicular, fifth intercostal space. Okay. All right. There's an additional step with listening to the bell, and that's sitting upright and then rolling to the side. But because you're already laying down, I'm just going to place this in the same location. Are you able to just turn yourself to the side?
Which way, doctor?
Towards me. Yeah. Okay, so I just need to place this first into the area. So if you're able to displace your breast tissue again. Okay. And then if you're able now to turn towards me. Yep.
Is that okay?
A little bit more. Yep, good. Okay, good. And from here on, are you able to sit up? Like to a seated position? Okay, good. Perfect. Sorry to make you do all that work. Have you ever listened to your heart before?
No.
Okay, because I want to give you a chance to listen to it yourself. I didn't hear any abnormal heart sounds, any kind of pathological S3 or S4. These are extra heart sounds, which could sometimes, so usually we have just two lub-dub, closure of AV valve and the semilunar valves, like I mentioned earlier. But sometimes we will hear different sounds like certain clicks, certain bruits and murmurs with the turbulent blood flow. We can also hear extra heart sounds when they're not synchronized. Okay, I didn't hear any of those, but I did hear something called like a heave. Now, a heave is kind of like a wheezing sound. I don't know if you can pick it up, but my cat is sleeping and snoring, and that's exactly how a heave sounds like. Just right now, you can hear it if the microphone can pick it up. So, having said that, that could be due to several things. People who have respiratory issues like asthma, sometimes you'll hear that wheezing, heave-like. Sometimes when someone has an enlarged right ventricle, such as in heart failure, because over time the heart's going to have to work harder and harder, and because the heart is a muscle, when you work out a muscle, it gets bigger. But the thing with a heart, with a myocardial tissue, unlike your skeletal muscle, which can rest after a workout, the heart continues to pump 24/7. If the heart takes a break, we die. So that's why the heart is the ultimate giver. Like what you're mentioning, it cannot take a break. It must continue pumping. And that electrical signal through the SA node must continue to pump. So if it's having a hard time because either the arteries are occluded and it's hard for the blood to circulate, then the heart will naturally enlarge to try to compensate for that inability to pump blood. The issue with that is intuitively you think a bigger muscle would make a stronger heart, But in this case, it's not always helpful because although the heart muscle is very large, it's still unable to meet the body's demand. So it continues to enlarge and enlarge until it becomes pathological. So that's why eventually we get something called heart failure. Literally, the heart just is not able to do its job. So sometimes we hear those in those certain conditions. Now, with heart failure, depending if it's left-sided or right-sided, can lead to something called congestive heart failure. So when the heart is not able to bring back the blood from the lungs can get filled with blood. And the lungs doesn't like an accumulation of fluid. It's like pneumonia. And then you'll hear all sorts of crackling sounds. That's someone with heart failure. We'll also see the JVD increase, the jugular venous distension. We'll also see ascites, just like in the hepatic liver condition, because now all this fluid is collecting into the peritoneal space. It's seeping out of the arteries and veins to collect all over the body. So we get someone who's swollen, having a difficult time breathing. You could see their pale or bluish tinge. That's a severe progression of heart failure. So what I mentioned is I heard a heave. So I can't make a clear diagnosis just based on that. You would need extra testing like an echocardiogram to visualize the heart, a 12-lead ECG just to see the electrical impulse to see whether it's working properly. And you may need a CT scan to just visualize the structures of the heart. But nonetheless, I want you to have a listen to it. Have anyone told you that you had heave?
Not heave, but I was born with like one less valve called B.A.V.
Okay.
Aortic valve.
Okay, so one valve is missing.
Yes.
Do you mean to say the tricuspid valve only has two valves, or the aortic valve only has two valves?
It's well, I just know that it's two valves that I have instead of three, so it must be the tricuspid that I don't have.
Okay. Yeah, so what you're mentioning is that you had a congenital condition where one valve is missing?
Yes.
Okay, and you're saying it could be the tricuspid valve, but it can also be the aortic valve.
Yes.
Okay.
I've never had any issue with it before, doctor. So
Okay.
I don't know if maybe that's what I was feeling. I don't
Mm-hmm. Well,
in January.
Well, we can actually investigate two situations together and how both, wherever the location of this missing valve, can actually indicate the symptoms. So if we go back to our diagram, bring back the textbook. This is actually a good diagram right here. So right over here, we have someone who is having congestive heart failure. You can see the ascites, round belly, yellowish of the skin. You can see their glassy eyes. You can also see some salivation, drooling. Their heart is having a hard time pumping blood into the body. Okay, so when we go back to those valves that you're mentioning, okay, so let's take a look at the heart and I think this is the best diagram to explain. Okay, so all right, on the heart here, we have four valves. One here, and one going to the lungs and one going to the heart. Okay, as I said, we have four valves. One of them only has two valves. That's the mitral valve, or the bicuspid. So the AV valve, the tricuspid valve, the first one, which is supposed to have three. So if it only has two, so think of a door, right? So the door lets people in and then it closes. It stops people from coming out. But if the door is missing one door and it's just opening and closing, so that means people can still enter and then come out. Similarly with your blood. Okay, so we said on the right side of things, deoxygenated blood comes from the inferior and superior vena cava to the right atrium, which then passes that tricuspid valve into the right ventricle, which is responsible for bringing that blood back towards the lungs. Now, if the blood is escaping the ventricle and going back to the atria, okay, what we're going to see is an increase. It's going to travel back up to the superior vena cava, and on this diagram, the superior vena cava goes to the jugular vein. So then we'll see increased pulsations in the jugular vein, which we measured earlier on. And if that becomes the backflow, becomes severe enough, it can push the pulsation upward. And what happens then, if over time that's not corrected, then this blood backflows to the liver, and then we get the ascites, the fluid in the abdomen. Now, if the location of the missing valve is in the aortic valve, as you said, it's a completely different location now. It's on the left side of the heart. So after the blood gets oxygenated by the lungs, it's brought back to the heart by the pulmonary veins into the right atrium, into the left atrium, to the left ventricle, then to the aorta, and it must pass through the aortic valve. So there should be three there, right? So if you only have two, then now it's back flowing to the left ventricle, and which could then backflow back into the lungs. So the symptoms would be different because it's not backflowing to the liver, creating the ascites and the spider nevi and the jugular vein distension. It's creating pneumonia because now the lungs are being overfilled with fluid and the lung is unable to bring it back. So depending on the symptoms you're having, depending on where the missing valve is, that could dictate the symptoms that you will have. And that's also the difference between right-sided heart failure and left-sided heart failure, right? Left-sided, more chest congestion. Right-sided, more hepatic congestion. Does that kind of make sense?
Is that why, doctor, if I lie down on my left side, it's uncomfortable versus when I'm on my back?
Yeah, because if you're lying on your left side, and this happens to, when we lie down, the fluid by gravity comes down, right? So if you're lying on your back, it comes down. This is why people who are pregnant, because now there's a baby occupying their abdominal cavity, they tend to urinate more at night because now the fluid is coming down and getting pressed by the baby to the bladder. A similar idea when you're turned to your left side. So all the fluid that is on the right side of the body is now coming towards the left side of the body. So that can put a lot of pressure into the heart because now we're returning it down into the heart. So that could be really uncomfortable. And there is actually a test called the fluid test wave, which we did in the abdominal exam in the video. For those who are interested, they can check that out. I'll also link that video into this video. And that shows how that fluid can shift. That you could check out that video and it'll explain everything. Okay, well, why don't we go ahead and listen to your heart. So what I'm going to do, is I'm going to have you listen to your heart. But before that, I'm going to have you listen to my heart. So that way you could hear the difference between my heart, which hopefully is working fine, against your heart, which has a heave. Okay, so before that, I'm just going to sanitize the equipment one more time. All right. Okay, so you can place this in your ears. Okay. S1 and S2. Okay. Okay, so you were able to hear lub dub, lub dub, lub dub. Okay, I'm going to place this on your heart and you can listen. I'm going to sanitize that one more time. Yeah, so can I place this on your heart? Okay, perfect. Let's start over here. This is the aortic valve. Okay, pulmonic. Okay, tricuspid. It's a little harder to hear with a shirt. And then if you're able to displace your breast tissue, mitral. Okay, all right. So can you tell me what you heard on my heart versus what you heard on your heart?
Yours is Dr. Lub dub, but mine is more like a whooshing sound. That's kind of like what I can hear the difference of the two.
Yeah, so that is the heave that we're talking about. Yeah, so if your if your body is not getting, so let's assume it is the aortic valve, which is supposed to pump out the oxygen from the left ventricle, from the lungs that's being oxygenated. Then if your body's not being oxygenated, it's like your oxygen tank is half. So you can imagine the impact of that in yourself. So it's like you're only taking half breaths. So rather than taking a full breath, you're literally cutting it in half, so to speak. So then the rest of your cells is not being oxygenated. So that can sometimes manifest as poor circulation. So it seems like you're fatigued all the time. If it's the aortic valve that's involved, of course, I recommend further investigation. But if it is the tricuspid valve, then we're going to see more of that fluid retention into the extremities as well.
Which would be the bicuspid for me.
Yeah.
Rather than the tricuspid, because everybody has a tricuspid.
Everyone, well, not most people.
And then there's some people that
Yeah.
have a bicuspid.
Yeah, I mean, the only way to find out is through...
And the heart doc, see a heart doc.
Yes, a cardiologist is a good person to start with. So then they can take the echocardiogram, CT scan if they need to be, and also your ECG. So that's a good place to start. And then from there, then you can start to help the fatigue once they find out a treatment plan. Okay, well, thank you so much for coming in. Do you have any questions before we conclude today's examination? Perfect. I just wanted to say thank you to anyone, to all of you who is still in our video. I just want to say thank you to everyone who continuously comment and share and like the videos, because that's the way the YouTube algorithm determines the value of my videos. It helps push it out to more people. Also wanted to say thank you to all my supporters on Patreon, because it does help fund the channel. So in any way you're contributing, whether through watching my videos, sharing, liking, commenting, or hitting that super thanks and monetarily supporting me through Patreon, I truly, truly appreciate it from the bottom of my heart, because without you, I wouldn't be able to continue to make these videos. So thank you again so much for all that you do to support me. And I hope to see you in the next video for more medical exams. I'll see you next time.